We are good to go. So, Josh Neff, we're here with you. You're from Centura Health?
I am.
So what's your role with Centura?
So I'm the Assistant Vice President of Integration and Rural Health. So I oversee all of our rural health initiatives across Colorado and western Kansas.
Oh, wow. It stretches all the way to Kansas. Wow. And how long have you been with that organization?
I've been with Centura about 4 years. I've been in healthcare my entire career, mostly faith-based nonprofit organizations like Centura.
Okay. And so tell us a little bit more about what Centura is working on, what they are doing to help address issues in rural Colorado.
Yeah, so Centura is the largest healthcare provider in Colorado and western Kansas.
Okay.
We've got 17 hospitals. We've got 22,000 associates.
So just a few.
Just a few, yeah. And that includes, we've got our Flight for Life program and then a number of ambulatory programs across the state as well. So huge footprint, huge presence.
Yeah.
Most people know us from our presence along the Front Range and predominantly St. Anthony's Hospital in Denver and then Penrose St. Francis in Colorado Springs. That said, we've got 15 other hospitals, and we're a 140-year-old ministry that started in Durango, Colorado.
Really? I didn't realize it started in Durango.
Yeah,
That's cool.
So Mercy Regional Medical Center was our first hospital 140 years ago.
Oh.
We had 5 women religious from the Catholic ministry.
Okay.
If you can imagine, we're asked to ride mules across the state of Colorado and build a hospital and start to deliver health care to a group of pretty rowdy miners.
Yeah.
Those women religious had no construction experience, no healthcare experience.
Okay.
But they took that task really seriously. And so our roots at Centura really are in rural healthcare. And if you look at where our footprint is in terms of not only the hospitals that Centura owns and operates through our 2 sponsors, so we are sponsored by the Adventist faith and the Catholic faith.
Okay.
But we also have 16 affiliated rural critical access hospitals.
Okay.
And so if you look at that footprint, the majority of the work we do is in rural Colorado and western Kansas.
Yeah. Tell me about how that works, the rural critical access hospitals.
So part of our vision is every community, every neighborhood, every life whole and healthy.
Okay.
So that doesn't just mean along the Front Range. And so our vision is a significant part of our overall global mission.
Right. And
we want to make sure that some of our most fragile communities in rural Colorado and western Kansas have access to care.
Yeah.
It's a completely different environment. Access to care is challenging.
Right.
Those folks don't live on the Front Range for a reason.
Yeah.
And they don't like to come to the Front Range, even if it's to get health care.
Right.
And then you couple on top of that kind of the agricultural type lifestyle where you may be on a tractor for 16, 18 or more hours a day during harvest or planting season. It's tough to just park the tractor, jump off, drive 2 or 3 hours into Denver or Colorado Springs to see your specialist, and then drive back. So what we do is through our rural physician outreach, we're able to take specialists out into these communities so those folks in those communities have greater access to care and that they don't have to leave their communities. The other piece that we do is we help these small critical access hospitals really lean into kind of system think. There are rural critical access hospitals are at risk, especially coming out of COVID.
Okay.
Typically, these organizations aren't operating with a profit margin.
Right.
Were it not for some tax dollars and some pharmacy dollars and some other things. And so what we try to do is allow them to stay completely independent, but start to think in terms of how systems would approach the delivery of healthcare.
Right.
So we talk to them about how to be more operationally efficient, how to invest the dollars through the foundation, how to think about improving access to care, thinking about different care models, embracing telemedicine, which is a great opportunity for us to use in the rural market, but our rural partner or our rural communities aren't early adopters, which is interesting.
Right.
The analogy that I've given to a number of folks is that we've got farmers driving around in a $750,000 tractor that's got touchscreen guided GPS that monitors the amount of nutrients per seed drilled into the ground.
Right.
But they're still using a Nokia flip phone.
Sure.
And they don't want to see a nurse practitioner, they don't want to see a PA, and they don't want to see them on TV. They want to see them in person, and they want to see a physician.
Yeah.
So figuring out how to improve access to care through technology and other sources proves to be a little bit of a challenge for us out there. So we just work with them to really think about how to look at things through a different lens. We don't force them to do anything. we really just act as a trusted advisor and a consultant for the most part to try to make sure we're driving long-term sustainability so that future generations in that community still have access to healthcare.
Yeah. So with telehealth, I mean, we've talked about that quite a bit in the rural communities we visit and stuff, just the equitable aspects of that. I'm curious, have you guys seen COVID affect the adoption of telehealth? Has that kind of leapfrogged forward a little bit?
So it's leapfrogged forward and then leapfrogged backwards.
How so?
So interestingly, it's been 2 years now, if you can imagine that. It's hard to believe we've been in this mess for 2 years. When COVID first hit, we had a significant uptick of early adopters, both on the provider side as well as the community side on telemedicine.
Right.
What we have seen now that we've plateaued, things have opened up a little bit, we're actually able to get some of these specialists back out into these communities. For probably the better part of about 8 to 10 months, we didn't have the ability to get our specialists into these communities because of all the COVID lockdowns and restrictions. And so what we've seen, though, is now that things have started to open up, that utilization of telemedicine has slid backwards. We're not where we were pre-COVID, but we're certainly closer there than where we were at the peak of telemedicine utilization.
Yeah.
And there's still some challenges, right? I mean, the physicians aren't being compensated well, if at all, for the telemedicine visits.
Right, the coding on that's tricky.
It is. We're hoping that COVID's going to push the federal government to embrace telemedicine, especially for the rural communities in a little different way. So
yeah, and with that, because I was wondering about the adoption rates and stuff with COVID. Obviously, everyone got a little more comfortable doing stuff online, and then the other aspect of that is, what is patient satisfaction like with? Obviously, there's the rural aspect of it, but now adding that telemedicine piece in, what's the patient satisfaction like?
Yeah, I don't know that anybody in the rural communities has specifically done any type of patient experience or patient satisfaction.
It's all pretty new, I guess.
Survey, a statistically significant survey, if you will.
Right.
But I think the early adoption really came from not necessarily because they were super enthused about it and enjoyed it, but it was the only way to access some of that care.
Yeah.
Rural folks like to sit down and have conversations face to face, right? You still, in the rural communities, a man's word and a handshake is better than any contract that they'll be willing to sign. Same thing goes for healthcare, right? They want to sit down, they want to have a conversation with their provider.
Yeah.
They don't want it to be limited to that 15-minute treatment time, so productivity and efficiency is affected and those kinds of things. And so all of those things that are so great about the rural communities that oftentimes the urban and suburban communities don't understand are the things that kind of get in the way to some degree for allowing us to provide help.
So tell me a little bit more about what you guys are working on this coming year that we're excited about.
Yeah, so for us it's a couple things. One, advancing our mission and ministry as Centura.
Right.
We intend to grow. We intend to serve more folks in Colorado and western Kansas. We need to do that for a number of different reasons. One, because our mission calls us to do that.
Sure.
And there are people that need that access to care. If we intend to continue to be the number one or number two health system in the state, then we have to grow at the same rate that our population and the economies are growing as well. At least, from a front range perspective. The challenge is the majority of those rural economies are not growing. Many of them are shrinking.
Right.
That's also a big driver for us to figure out how we can help these rural critical access hospitals come out of COVID and not be in a place where they're having to think about closing their doors. These critical access hospitals are typically the number one or number two employer in their county.
Right.
And they typically employ some of the highest wage earners in the county. If the hospital dies, the local economy dies.
Yeah.
If the local economy dies, the hospital dies. And so there is an embedded connection between the two that a lot of people don't really necessarily understand. And so for a rural community to thrive, they need a really good, solid healthcare program. If those rural communities want to attract folks to move back into those communities, they want to go there and know that they don't have to drive an hour and a half or 2 or 3 to get to a hospital if something happens and they need it, or just for their primary care.
Yeah.
And so part of what we intend to do this next year is really kind of build on the framework that we've put in place, which is Centura 2025. That really gets us focused on making sure that we're improving access to care addressing social determinants of care or social determinants of health, really looking at what we're doing to help eliminate food deserts. So for us at Centura, healthcare is less about seeing a doctor when you're sick and improving the overall and total health of a community.
Yeah.
And so how do we do that? There are food deserts in Denver.
Yeah, absolutely.
There's also food deserts in Alamosa. There's food deserts in La Junta. There's food deserts in Eads.
Yeah.
All through the Eastern Plains, Western Slope. And so we're trying to work with folks to understand how do we address behavioral health? How do we address making sure that people have healthy things to eat?
Right.
And all of that improves the overall total health of the community.
Yeah.
So those are some of the things that we're going to be focused on with a high degree of kind of rigor and disproportionate investment into those kinds of strategies.
Yeah. I know just in our conversations with all these communities, something that comes up frequently with healthcare especially is, like you said, attracting these providers back to those communities and keeping them there. We have a lot of issues just almost that recruitment to a community. Is there a way that you guys are working to address that?
So part of it is we have to be open to alternative care delivery models.
Okay.
So that includes telemedicine, but it also includes, a nurse practitioner care delivery system, a PA care delivery system,
right,
in conjunction with an MD or DO provider.
Yeah.
It's really, really tough
right,
to get those folks to come to the rural communities. They typically have to be from a rural community and have a passion and an understanding.
There's a partiality there.
Absolutely. They have to also understand that, there's probably not a Walmart or a mall or something to that effect real close by.
Right.
So, and we joke, we say, that's sometimes you find a great provider, but the sell is really their spouse or partner.
Absolutely, 100%.
Because they're going to be the one that's sitting at home trying to figure out, how do I work remotely? How do I work at all? And,
right,
if I want to, there's no just running to the mall on your day off. And so it takes a pretty unique complement of both of those folks for us to be able to attract. We've been recruiting in one particular organization that I work with. We've been trying to recruit a primary care doc for over 18 months.
Wow.
We've had one person apply for it. And so it is really tough. Now, again, those communities aren't early adopters of alternative care models.
Yeah, okay.
But if they intend to have healthcare in the future, those folks have to embrace that.
Right.
And in some communities, that's been forced by the hospital because they didn't have any other option.
Uh-huh.
And then retrospectively, you look back 2 to 3 years, and folks have adopted it because it's what is there.
Yeah, yeah.
And I've literally had conversations with patients in our rural communities where I've said, well, who's your doctor? Well, my doctor is Amy. Well,
Amy's not a
nurse
doctor.
practitioner.
Yeah.
No, she's my doctor.
Right.
And so that whole mindset, sometimes you have to force that to get some of the mindset and culture to shift. So
Interesting. Yeah, I mean, it's really an interesting combination, just like I said, in our conversations around these communities, to hear all those issues, the attracting the right talent, keeping them there, access to care, quality of care. It's an interesting thing. Like you said, that early adoption piece, it really, I think, it asks a lot of the leadership there just in the community, town councils and things like that, to kind of drive that and give those opportunities to expand. I know, a lot of our partnerships are working on that, improving maybe the offering the community has for these providers, but also, like I said, their families.
Yeah, the other interesting thing is the lifespan of a physician in a rural community is about 2.5 or 3 years.
Oh, really?
And a lot of these folks, the days of your local doc having been there and delivered you, delivered your kid, your grandkid,
right?
Those days are long gone. And those docs are all starting to hit retirement age, and those communities want another doc that's going to come in and be there for 40 years to practice, and that's just not the culture of the physicians that are coming out of medical school today.
Yeah.
And so that proves a big challenge as well. Now, there's some things that we can do to incentivize providers to engage in rural communities. Mm-hmm. That said, those folks are going to come and do their 2 or 3 years. They're going to check that box. They're going to get some of their medical school loans forgiven, and then they're going to be on to the next place, probably a bigger city.
Right.
And so it does create some challenges for the community to understand, golly, why can't you guys just get a physician in here?
Yeah.
It's just not that easy.
Yeah. So circling back a little bit, but kind of finishing up, what should we be excited to look forward to with Centura Health in the next year?
Yeah, watching us build flourishing communities all over the state of Colorado and western Kansas, and doing things that most people would not attach an assimilance to healthcare or being sick and providing health. We're engaged in a whole lot of things that are going to build healthy people, vibrant communities, and empower our frontline caregivers to be the best that they can be and to do what they're passionate about.
That's awesome. That's exciting.
It is.
Cool. Thank you so much.
Absolutely.
For being here.
You bet.